The chair lays out Senate Bill 170 and recognizes its author, Senator Perry, to explain the bill. I do understand there is a committee substitute. Would you like for us to send that up?
Yes, ma'am.
Senator Perry sends up the committee substitute to Senate Bill 170. The chair lays out committee substitute for Senate Bill 170 and recognizes its author.
Madam Chair and members, thank you for the opportunity to lay out Senate Bill 170. Members, we do a lot of things under the Pink Dome when we're down here every 2 years, and most of them are hopefully life-changing and important. I would suggest to you that Senate Bill 170 is probably one of the most important bills that most people probably would not understand or appreciate unless they deal with rural hospital care. 21 rural hospitals have closed in Texas since January of 2013. Despite a long-standing legislative intent that rural hospitals be paid their cost or near cost to treat Medicaid patients, in recent years we have drifted so far off that course that HHSC now estimates that rural hospital underpayments to be well in excess of $100 million a year, or $200 million a biennium, all funds. In 1993, following a similar wave of rural hospital closures, the legislature placed a rider in the budget requiring that rural and small hospitals be paid the cost to treat Medicaid patients. The action worked. The rural hospital closures in Texas dropped dramatically. One reason for the underpayment comes from the transitional to managed care private insurance companies. The base payments that HHSC asked the MCOs to follow for rural hospitals was based on 2010 cost data. Rural hospitals cannot continue to absorb this underpayment. Besides the closures, more rural hospitals are ceasing delivery and labor services because of the underpayment. Of the 161 rural hospitals, only 66 now provide baby delivery, and more are planning to end those services. Senate Bill 170 will direct HHSC in state law codifying, rather than just a budget rider, that rural hospitals are to be paid substantially close to their cost to treat Medicaid patients, so that when we can stem the tide of current rural hospital closures and ceasing labor and delivery service in rural Texas. The substitute differs from the original file version in that sub reverts back to current prospective payments with a contingency that true cost reimbursements get implemented in 2022, subject to federal approval of the change. Members, I've got 39 rural health care hospitals in my district. I'm the largest of the 361. I have 39. It's safe to say that 10 of those will no longer be open by the time we come back next session, possibly more, if we don't do what the state has said it's supposed to do for years now, and that's reimburse Medicaid at cost. It's been an extremely frustrating process over the last few sessions because the, quote, cost was undeterminate or best guess or woefully understated for years. Thus, we have had more closures and probably more on the horizon. This is one of those bills that it's really not an option not to pass it through the system with a rider that's currently in discussion at Article 2. I'm understanding that would be implemented to fund rural health care hospitals. Let me give you a little bit of a history on the payment activity. In March of 2017, HHSC estimated that it was a $66 million number, and understanding that that's the federal portion of that is somewhere between 50 and 60%, depending on the FMAP. In September 2017, Commissioner then stated that at the worst case scenario, we were shorting our rural health care $66 million, which still is a large number. Today, because of pushing, the HHSC estimate is $170 million of all funds currently not being funded to our rural health care hospitals. It's just time that we step up and honor that. You know, people get confused. So first of all, a community should have triage and ER services no matter what size. Secondly, sometimes my urban partners forget that they may travel through those rural districts. If they have a hog that flips their car, if they have a deer that comes through the windshield, if they're snake bit out on one of the trails, whatever that case may be, if they find out that their rural health care clinics are no longer available, then they may find out they have no health care and to get them to the next urban center for treatment. So this is a statewide priority issue. Are we going to prioritize health care no matter where you're at and do what we've said we've been supposedly doing or expected to do, and hopefully prevent and kind of mitigate the closures that are going on? So a couple of things to point out. I'm not into looking back at how we got here. There's lots of reasons we're here today, and we could find a lot of people to point fingers at and blame. But today is about what are we going to do going forward, honor our commitment that we've had in riders and rules. Are we going to actually codify our responsibilities to our real healthcare providers? And that is the question of the day. The dollars are big, but I can make the argument as going through the finance and hearing that $50 million here for non-specificity for this purpose or that purpose, or a lot of different agencies asking for a lot of different money, a lot of different people asking for exceptional items, all well-intended and well-good, that there's probably no one better place to spend this kind of a money to prevent rural health care from being a foregone conclusion that that's just all they're going to get and close their doors. So with that, we've got lots of resource witnesses. There's some big discussion. We've moved to MCOs, and I'm not an anti-MCO person at all. They tell me that this money has always been a pass-through, so it's not an MCO issue. It's directly related to an input issue from the state side as to what we were paying those rural medical aid. So this isn't about any one person or party not doing their job. It's just we're here now. We recognize that the cost has been woefully understated, and it's time to move forward with the correct cost application.
Thank you. Senator Perry, I know you've been working on this. I've been working on it in kind of a different way, but the same. I've taken this language out of a bigger bill that I had, or omnibus bill. And let me ask you this question. As you mentioned, there's been riders that have attempted to direct $60 million. There's some that say it's there, some that say it's not. What's your thoughts on that?
So it's been a little frustrating because we've argued about what the number is and that there's no legitimate source to determine that. Now we have determined we can tell what the cost is. There was fingers pointing that it was HHSC not funding it, or it was MCOs not passing it through. I think it is a state, and again, no reflection on any one person or any process inside of HHSC. We have not put the money for it to pass through. There's a big debate. This is a direct reimbursement, a quote, carve out around MCOs. That's not the intent. We just want the money to get to the rural care. And if it goes through the MCOs and it passes through MCOs to those providers, that's perfectly acceptable, and it doesn't disrupt the MCO network that we've established. We just need to know the money's big enough coming through that what was intended. There's also a big discussion about complicated ways to come up with the cost, and I think we'll hear testimony today that there is a very systematic way of going about of getting that cost for Medicaid providers. It's already reported, it's already uniform, it's something required by CMS that we do, so we can nail down what the costs are. We've eliminated the biggest barrier to doing what we said we were going to do by coming up with a way to determine cost efficiently, effectively, and accurately. That's auditable, that's responsible, and we can get there today based on that method, and we'll hear those testimonies. But I'm disappointed that we're having closures only to have the information look back now and says, oh, we were right, that we were not funding the Medicaid cost by the tune of $120 million if you go with the current estimate. We've got 66, I think, in the current budget, and that's up from where we've been in the past, and the number's now 170 or 170 plus. So it's been moving around, but I think we've all determined this session that no, it's really been that short.
Okay. Other questions, members? We do have two witnesses invited testimony. The chair calls Don Macbeth. And Jim, in my area it would be Yannick, but it might be Janik. And it depends on what part of Senate District 18 you're in, if it's Yannick or Janik.
Yannick.
Yannick. Well, you're from Colorado County, so I should have assumed as such. But there used to be a guy named Kyle Janik, which we gave him a hard time that he Americanized his name there. said Yannick. Don?
Thank you, Madam Chair, members of the committee. My name is Don Macbeth. I'm with the Texas Organization of Rural and Community Hospitals, and we represent the remaining 161 rural hospitals in the state of Texas. I appreciate so much the opportunity to come and talk to you today about what is an unfortunate lingering problem in the state of Texas. Candidly, Senator Perry has done a yeoman's job laying out the issue and the challenges, and actually took away about half of my testimony. So, but and Senator Perry, rarely would I correct a state senator in a public forum. You said you have 39 rural hospitals. You forgot one of them closed in July, so you have 38 remaining. Just to reiterate a couple of points that Senator Perry made to the committee, we do have a lingering rural hospital closure crisis in Texas. As has been mentioned, 21 Texas rural hospitals have closed in the last 6 years. Many more of those rural hospitals are either in bankruptcy, they are in financial stress, and many boards are today even discussing closure. The other side of that ledger is a number of services that are being reduced in the rural hospitals that remain. We'll talk a little bit this morning about labor and delivery specifically, and I've passed a map out to you which will show you all of the rural hospitals in Texas, and then delineates which of those rural hospitals still provide labor and delivery and which do not. And you'll see very quickly on that map, we have a lot of geography in this state where you cannot get a baby delivered. And I think in a state that has been very concerned about newborn mortality rates, that has moved forward very boldly with the neonatal and maternal designations, but yet we have a large area that you just cannot get a baby delivered through the normal traditional means. We believe in our association that there's many reasons rural hospitals close, but we sincerely believe in our heart, and we know that a major driving factor is the Medicaid underpayment. Again, addressing the issue of labor and delivery and why those decisions are being made. Across Texas, approximately 50% of the labor and delivery, the babies are delivered by Medicaid coverage. In most of rural Texas, that's 70%. So obviously when you have an underpayment, that's disproportionately amplified in the rural areas. Chairman Colcourts, one thing I'd like to just touch on again without repeating all of the bill layout from Senator Perry is the fiscal note that's been attached to this bill. Obviously, as Senator Perry said, the underpayment apparently has grown tremendously in the last couple of years, and there may be some more due diligence needs to be done to get a handle on that. The one issue I do want to address with the committee is the fiscal note calls for adding 8 FTEs at the Texas Health and Human Services Commission. We do not understand that, and we do not understand the need for 8 additional FTEs to calculate the cost of Medicaid in each rural hospital. We recently demonstrated for commission staff a fairly simplistic way that you can use a Medicare cost report and come up with at least a very close estimate. The commission staff did essentially reject that in conversation and said they did not believe that calculated the actual true cost. I won't debate that point, but what I do want to share with the committee, it has been related to us by 2 different financial consulting firms that prepare these cost reports in rural hospitals, that the process we outlined for the commission is the very same process that Medicare uses to do the cost calculations in a critical access hospital. So my question would be, if it's good enough for Medicare, why wouldn't it be good enough for Texas Medicaid?
Thank you, Don. I actually am going to call up at the request of Senator Perry 2 resource witnesses, Charlie Greenberg and Victoria Grady with Health and Human Service Commission.
Senator Colcourts, I have follow up with.
Yes, Senator Perry.
So, Mr. Macbeth, on the last point you made regarding the complexities of determining cost, are those Medicare cost reports required by CMS annually?
Yes, they are required by CMS. Every hospital in the country submits a cost report to Medicare. It is essentially the equivalent of their income tax return.
Correct. So are those costs auditable and typically provided by a professional licensed cost report person?
They are auditable. They are in fact audited. They're audited by both CMS at times and then even outside parties.
Outside party. Are they uniform in that when you put a cost particular on a line item, that's the same cost item for every Medicare, Medicaid recipient across the country?
Yes.
Uniformity.
Yes.
It's not subjective. Assuming the people that are putting the data in are properly trained, that would be a fairly accurate statement of what truly is costing that to operate.
I think it's about as accurate as you're going to get. There's always some debate
Sure.
as to what constitutes cost, quote unquote. But what we had proposed is the same standard, again, as I said, that Medicare uses for calculating Medicare costs.
So if a provider is currently using the rules as promulgated through CMS regarding cost reporting, there should be some assurance, and having multiple eyes verify that data over time, that is the accurate cost that we have all agreed on can keep as a standard cost item.
I believe it would be an accepted standard to the federal
And the
government.
ability to pull that number today would take you how long if you had a computer in front of you?
Well, if you have the cost report from each rural hospital, and keep in mind of the 161 rural hospitals, approximately 150 are considered rural in the state's Medicaid program. We think if you have the cost reports, it takes about 15 minutes per hospital.
And you demonstrated that as much with the
Yes.
agency. Thank you, sir.
Thank you. Would you like to hear from the resource witnesses or our invited
Well,
testimony first?
Do you want to let the public?
Let's hear
invited
from
go first?
our invited testimony, and then we'll go to the resource witnesses. Mr. Yannick, if you would, state your name for the record.
Yes, my name is Jim Yannick. I'm the CEO of Rice Medical Center in Eagle Lake, Texas. Madam Chair, members of the committee, I cannot thank you enough for the honor and privilege of testifying on behalf of truly all the citizens of the state of Texas. I appreciate Senator Perry mentioning that rural hospitals don't only serve the rural communities, but they also serve all of us as we travel from one destination to another, and we never know what will happen in between. The inadequacy of Medicaid reimbursement to hospitals is devastating and very problematic. You all have heard that and you're well aware of it. Thank you, Senator Perry, for pointing that out. I'd like to share with you, if I may, some experiences and observations of one hospital operator. Our hospital has struggled for 4 years over the proper alignment of services. Which services do we need to provide to our community? Which ones are indicated? And perhaps which ones are not justified by volumes and need from the community? And as a result, we discontinued some, bone density, nuclear medicine, but we looked at some other services as well, and labor and delivery was one of those. For over 3 years, we struggled with the realization we could no longer justify providing that service at the tremendous loss it was being incurred by the hospital and jeopardizing other critical services. And it's also a very emotional service. It's a storefront service. What greater privilege and honor is there in life than to help bring a life into this world? So as our hospital district board and the hospital operating administration looked at this, again, for 3 years, we finally came to the realization we simply had to do it. And it was a difficult decision. I don't mind telling you, I've been in this business over 40 years, and it was the most traumatic period of my life. At this point, I still wonder each and every day whether or not some mom, probably Medicaid, low income or uninsured, because they're the ones the most susceptible to not having the dependable transportation and some other issues that they have to deal with, suddenly having an emergency pending childbirth and show up in my ER. At this point, we have very fortunately been able to handle each and every occurrence and transfer them out when necessary, but again, it's something that keeps me awake. What we do for a solution, I don't know, but I'd like to share with you something. I've been at this hospital for 7.5 years. In that period of time, I've had 2 adjacent hospitals closed their doors. One hospital tried to reopen and had to close again. They're still closed. Another hospital, which was a former regional medical center, reopened as little more than an outpatient services hospital. They do not handle inpatients at this point. We have two other adjacent hospitals, which are, one reportedly due to close in May. I heard a report just this morning, about 9 o'clock, that they have found a supposed white knight, which is going to help manage them moving forward. We hope and pray that continues. But the other one apparently is on financial life support. I don't know what the solutions are. We all have a very difficult challenge in front of us. The one thing I do know is that I and my colleagues will pledge you all every single effort and resource we can muster to help solve this for all of our citizens. I would happily entertain any questions.
Thank you, Mr. Yannick. Senator Campbell. And the chair recognizes Senator Campbell as being present. Members on the bills previously voted on, there has been a motion to accept a motion in writing from the members not in attendance. It shall not change the outcome of any bill. If there's no objection, that motion is accepted.
Thank you, Madam Chair. Thank you both for Mr. Macbeth and the CEO of Eagle Lake Rice Medical Center. So, Madam Chair, I work in Colorado County. One of my other jobs, been there for 25 years. I can't tell you members how important it is for us to find resources to keep our rural hospitals open. Everything from labor and delivery, which I'm most passionate about, because I want them delivered in the labor and delivery rooms, not the emergency room where I work. I've taken care of enough precipitous deliveries in my life that I don't want them showing up in the ER. And I know Chairman Colquhoun is working on a bill like that. But I can't, I thank Senator Perry for bringing this bill because we've got to find the resources. And I know for labor and delivery, trying to find, make sure our family practice docs that have been delivering can continue to deliver. And y'all didn't have an anesthesiologist available. You used CRNAs, is that correct?
We did suffer some interruptions in anesthesia coverage, and that's something that goes unthought of oftentimes, that anytime you do a delivery, anesthesia has to be present 24/7, that availability.
And I point that out, Madam Chair, because CRNAs are helping us, they're bridging that gap from urban to rural when we can't get an anesthetist out there. But we can get CRNA. So that's something they have to enter in, whether they're going to keep their OB department open. If they have CRNAs, that's a step because they're out living in the community. The anesthesiologists are in the urban centers as a general rule. So I know that enters into not only labor and delivery, but other services you provide, such as surgery services in your OR. But anyway, thank you, Madam Chair. Thank you, Senator Perry, for bringing this forward. Thank you for your testimony.
Thank you. I know, Senator Perry, do you want to ask our resource witnesses a couple of questions?
I do have a few questions for the resource witnesses.
Senator Johnson, did you have a question?
I was going to hold mine until our last resource witness speaks.
We'll start with Senator Perry, and then we'll go to Senator Johnson.
A couple of questions, or 3 questions actually, specifically to HHSC. And first of all, I want to preface again, this is not a who did it, why did we get here, what happened. This is, we're here today. I want a couple of questions. So, first of all, you guys now work through the MCO network. I'm told, and we don't have that resource today, but MCOs are purely a pass-through on this issue, that rural health care passes through MCO. Can you confirm that the dollars that go in from HHSC to our MCO network are truly getting out to the rural hospitals dollar for dollar? Is there an admin fee that's carved off? I mean, what is the arrangement from respect to the rural health care dollars going through the MCO network?
And before answering, please state your name for the record and who you're with.
Victoria Grady, I'm the Director of Rate Analysis for the Health and Human Services Commission. So we have an actuarial analysis that establishes our capitated rates, and our Chief Actuary isn't here today, but I'll do my best to answer in her stead, and then if there's any more detailed questions, we can get back to the committee. In the case of rural hospital reimbursement in the managed care environment, it's not what we would categorize as a pass-through. Pass-through payments are not permissible per our federal regulations. However, we have done a review per Rider 52 from the past legislative session regarding the level of reimbursement. And what we see is that in most cases on the inpatient side, managed care plans are paying at or very close to the fee-for-service schedule. They're not required to. They have negotiated arrangements with each hospital as their own providers within their networks. On the outpatient side, it was less clear, and we weren't able to ascertain as specifically what the reimbursement levels were, but we did see that on the inpatient side.
So for the layperson, i.e. Charles Perry, what you just said is we really don't know if what the state is putting into this reimbursement, that it's all flowing to the direct reimbursement to the rural health care. For whatever reason, what I heard you just say, and I don't want to put words in your mouth, if we put 60 million in, we don't know that 60 million got to our rural health care hospitals, be it outpatient or inpatient.
So we, on the inpatient side, see that they're paying at about the fee-for-service schedule. Typically, they were paying around 100% of the fee-for-service schedule, in some cases 105%, and in some cases 95%. On the outpatient side, we do not have a directed payment program, so we don't have authorization from our federal partners to allow us to direct the managed care organizations to pay a specific amount. And so while we looked at the outpatient claims, it is, as you pointed out, less clear, but we do have clarity on the inpatient
Of the
side.
inpatient, outpatient, which is the larger dollar?
I believe it's outpatient services.
So the largest dollar, we're not quite sure that we can support that it's happening the way we think let me ask this, has it been clear that the state's been committed to making sure reimbursement to rural health care costs are at Medicaid cost?
So we, at the point in time that we set the inpatient rates, set them back in 2013 in order to reimburse rural hospitals at 100% of their then costs. We haven't rebased those rates. On the outpatient side, the legislature made an investment in the 2015 session, and then that was reiterated again, I think, in the 2017 session, and we did increase the capitated rates to account for those increased payments to the rural hospitals that were anticipated.
So, and again, it's not directed to y'all. Did the state legislature get to Medicaid cost? I understand we increased monies, but were those increased monies reflective of actual costs that the rural hospitals are incurring?
So on the outpatient side, we have kind of 4 areas that we look at. So on general outpatient services, yes, the legislature invested funds to increase rates to approximately 100% of costs. For non-emergent ED visits, there's been a policy choice in place for many years to reimburse at only 65% of costs. And so we have funded 65% of the non-emergent emergency room visits. However, that leaves 35% that has been intentionally unfunded. And then we have 2 other types of services that we reimburse for, clinical labs and imaging. And in those cases, those are both reimbursed not on a cost basis, but on a fee schedule basis. And those have not been part of the conversation as explicitly. And I think one of the things that has changed the estimates coming from HHSC, as you pointed out, from 2017 to now, is that we've been mostly talking in the past about general outpatient and inpatient. The costs that we've given you now include what we calculate are the unfunded costs on non-emergent ED, clinical labs, and imaging in order to give a fuller picture of the reimbursement experienced at the hospital.
So the way the bill reads today is the sub moves it back to prospective. By 22, y'all would have put request in for federal approval of a retro look, so that come 22, we would hopefully be closer to cost every session. But at 22, we could have kind of a look back and a settlement similar to what we do through corrective health and stuff. But are y'all in the process of, assuming SB 170 were to pass, are y'all positioned in a way we can get CMS approval on getting the Medicaid cost up to speed and the reimbursement or retro look back after 22, so that there's a settlement provision, if you will, to square up based on cost data? And that's my last question here in a second. But are y'all in a position as an agency to move forward if SB 170 gets through the hoops?
So I think we're certainly in a position to make sure that the rates are adjusted using the prospective method. In a managed care environment, we have federal regulations, specifically 42 CFR 438.60, that restricts the agency from doing basically wraparound payments in a managed care environment. And so we would have to work with our federal partners to determine what the basis that we could do those ongoing cost-based reimbursements were with a retroactive settle-up. We, I think at this point, are uncertain how we could do that within a managed care environment, other than to increase the capitated rates at such a level that the MCOs would be able to reimburse at 100% of cost for all services at all times.
Final question. You heard the discussion about how we obtain cost data, and I personally am very familiar with cost reports. In my profession, we have cost report providers. I am not licensed to do those, but I deal with those with several clients. They're very uniform, they're very consistent, they're very deadline driven, they're very much scrutinized by multiple levels. Why would the agency not see that as a benefit in order to obtain cost data on an annual basis? I mean, those reports are due every year, and so they're available, they're quick, they're uniform, they're promulgated, they're federally mandated. What would be the hesitation from the agency being able to utilize that rather than creating another bureaucratic level to try to obtain these costs?
I think the agency would want to collect cost data and calculate costs in the most efficient way possible. One of the challenges we have with the cost reports and the method that Torch has been discussing with us is that their method would take fee-for-service days and fee-for-service costs, try to extrapolate from that a per-day cost, and apply that as a multiplication factor against the managed care days. But there's different populations of clients that are receiving different types of services, and so the fee-for-service costs may not be representative of what is being experienced in managed care. Additionally, the way that the state reimburses in fee-for-service may not be representative exactly of the way that the managed care organizations are reimbursing, and so we wouldn't be able to confidently say that those are a direct comparison.
So if the state's committed to funding Medicaid costs in rural health care, it shouldn't be not determinate as to what that cost looks like based on a methodology that an MCO may adopt that's different or unique than HHSC. The cost is the cost. So I'm a little perplexed that your concerns would be, we have this different formula for this reimbursement, and we have this when the state's policy has always been, we need to do what we can for rural health care, and that's Medicaid cost reimbursement. So I think internally, you guys need to have a continuation of a discussion at what the most efficient way looks like, and where we have verifiable, auditable, uniform, mandated data, and it's accessible over the internet for any and all Medicaid recipients on any given day for last year's data. That only makes sense to me. So I'd like to have a conversation probably off in my office on the details of what you're talking about. But what you just said is my concern. MCOs have a methodology and we have a methodology, and there should be one methodology. And what I hear is the state has a desire to make sure Medicaid cost reimbursement in rural health care is at cost, regardless of who's the payer source. If we choose the MCOs to pass that through, so be it, but there shouldn't be two differentiating formulas that distinguish between cost differentials and under their formula reimbursement. So more than happy to have a conversation on what that mechanics might look like, because the devil's in the detail. I'm not about creating another agency, bureaucracy to determine this, to get in the way of MCO. That works well. We just need to make the inputs right. Thank you.
Senator Johnson.
Thank you, Madam Chair, and I want to commend Senator Perry for recognizing the dire, serious, and tragic closure of rural hospitals and being willing to commit state resources to providing these vital services. And looking at the overall context, I'm sorry, Madam, I forget your name.
Victoria Grady, sir.
Last name again?
Grady.
Grady, thank you. You mentioned that what we're addressing here, we have the intent to intentionally fund what we intentionally don't fund each year in the case of rural hospitals. Is that correct with respect to Medicaid reimbursement rates?
Yes.
And overall, what we're talking about is the struggle that rural hospitals have because reimbursement rates are actually calculated intentionally below cost, correct?
In certain cases, yes.
All right, and Mr. Yannick and Mr. McBath, is some of the burden that rural hospitals bear due to uncompensated care in addition to the problem with low reimbursement rates?
That is correct.
And is it a significant portion?
It's a growingly significant portion.
And for patients who are enrolled in Medicaid that are visiting your rural hospitals or urban hospitals for that matter, is there a cost-sharing ratio between the state and the matching dollars from the federal government? As in around 40% from the state, 60% from the federal government?
Yes.
If those uncompensated care patients were picked up under the federal Medicaid expansion program, would that cost sharing shift to 10% and 90% respectively?
I cannot comment on that. I can say this, we do have offsets in funding, such as the 1115 waiver, diswritten and uncompensated care. Our hospital and our organization has recently projected out that starting in 2021, we will be losing a magnitude of millions of dollars because of the recent changes in uncompensated care. And from an administrator's perspective, although the 1115 waiver and the district program have literally kept my hospital open for the past 7 or 8 years, it's not lost on me that we're receiving offsets for services we provided sometimes 2 and 3 years before, below cost, and yet I've had to hire a multitude of FTEs in order to be able to perform the functions necessary to get those dollars back. So it is there and it is possible, but there's an additional expense for us operational in order to achieve it.
And it sounds like what we're doing here is an important step towards ensuring the financial viability of your hospitals, but with the coming phase out, it may not be enough. You comment on that?
I can assure you that is correct.
Thank you. I'll pause there.
Thank you. Thank you, members. Any other questions for this panel? We appreciate y'all being here today. We will leave Senate Bill 170 pending until later in the hearing. Passing the gavel to Senator Perry.
Chair lays out Senate Bill 23 and recognizes its author, Senator Colcourse, to explain the bill.
Thank you, members. Members, Senate Bill 23 clarifies the existing rights of a living child after an attempted abortion or premature birth to include the relationship between the child and physician after birth, similar to the rights of